if you're an athyroidic individual, it's very, very hard to get the thyroid medicine adjusted. You have nothing in your system to fine-tune the thyroid hormone whatsoever. Huge difference. And of course, if you save the whole thyroid, you're even better off.
Right.
It's very promising. I really enjoy seeing that we're able to save thyroids and able to prevent aggressive surgery in patients.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today, I have the pleasure of bringing you an in-person episode with Dr. Luisa Leal and Dr. John Interlandi of New Horizon Diabetes Clinic in Nashville, Tennessee. Originally from Colombia, Dr. Leal opened the doors to her practice in 2016, offering the local Spanish-speaking population access to a bilingual specialist in state-of-the-art diabetes care. Dr. John Interlandi, a formerly retired endocrinologist with an extensive medical background in the Nashville area, came out of retirement to join Dr. Leal in her pursuit of providing Thyroid RFA in 2021. Their individual skill and experience complements one another, uniting in a team approach unlike any other practice I have seen. I'm grateful for the opportunity to visit their clinic and speak with them today.
I want to hear about your backgrounds and what brought you into this teamwork partnership that you've got.
He has all the experience, many years. And when he decided to retire, I came into the endocrine world about in 2012. And by then I have already opened my own business 7 years ago, and I needed a person who can help me to keep moving with the business and be my supervising physician. So I asked Dr. Interlandi if he was willing to join me, and he said yes to the rest. So here we are. I was born in Colombia, South America, 50 years ago.
No.
Today, 50 years ago. And moved to the United States 30 years ago, and I did all my schooling here. I did my undergrad at University of Phoenix with 2 masters. Then I went to Vanderbilt and I did my nurse practitioner program and the doctorate program. I graduated with the doctorate program in 2014, and I was by then working already in the endocrine field.
Wow.
And I love it from the first time.
And you came out of retirement to do RFA, to team up with
Yes.
Dr. Leal.
Yes, I did. My name is John Interlandi. I'm an endocrinologist. I took my endocrine boards in 1981. Practiced full-time at Summit Hospital, which was also named earlier Donaldson Hospital. I practiced there for basically 40 years. The whole time I'm going to these thyroid meetings, and these Italian endocrinologists are talking about laser ablation and radiowave ablation. And I'm like, when is this going to come? When is this going to come? And I remember I had a conversation with Roberto Valcavi about 20 years ago, and he said, I don't know, John, you're looking kind of old. It might not make it there before you retire. And you know what? I decided to close my office in 2019. And if that's the year it gets approved. I've had obviously long-standing interest in endocrinology, but I practiced all of endocrinology when I was in practice. But then when I came back out of retirement, I decided to just do thyroid and parathyroid. And to do a lot of supervising. They can call me about a difficult case, which she does sometimes. I can do that by phone or by computer. So that allows me to be active as an endo, but really I only have to actually go somewhere once a week.
Oh, how nice.
As soon as the RFA equipment came out, she surprised me. She just went out and bought an ultrasound and an RFA machine. I was like, wow, really?
And now you have taken off and you're doing these procedures. We just filmed one today and then met another patient who's already had one and has had great success. So tell me a little bit about how it's going.
The procedures are going well.
Mhm.
I'm
Mhm.
very excited about the progression of our training and the success of the nodules in patients. We appreciate the kindness of patients in trusting on us and saying, okay, go ahead and do it. The reduction in volume has been approximately 50%, which is what we expected. We have other patients that already completed the year and still the nodule is still shrinking a little bit. So it's very promising. I really enjoy seeing that we're able to save thyroids and able to prevent aggressive surgery in patients.
We've done somewhere between 20 and 30 now. We haven't had a single complication, nerve irritation, anything.
That's great. I've witnessed several different physicians doing these procedures, and you guys really took your time and made sure everything was done just
Yes.
right.
Yes,
know, did not
safety
rush it.
is our motto the whole time. Safety, safety, the patients first. Like today, for some reason, the pump was not pumping.
Mm-hmm.
And until I didn't see the temperature in the right level, I wasn't going to,
Mhm.
start the RFA. But that's always our main focus, the safety of the
Mhm.
patient. Because we want the patients to be well and not to say, oh my gosh, they caused damage or they did this. No, we want everything to be successful.
It's important to walk into the RFA room acting like you've just meditated. You're just kind of like,
Yeah. It was very calm in there, very
Yes.
relaxed.
yes,
Did not feel stressed. The patient was very relaxed and calm. Everybody was calm. It was great.
yes, it was.
Have you had a lot of patients be interested in this in your practice, or have they mostly come from outside the practice looking for RFA?
A lot of the patients have come from Dr. Interlandi, patients that he brought from his private practice. The newer patients have come from here. I always tell them, well, your nodule is growing. These are the alternatives. Yes, we're the first ones in Nashville that we started with the RFA.
You are not far from me personally. Where I live is only about 2 hours away, and so I know patients that will be more than happy to drive 2 hours to have their thyroid nodule treated and save their thyroid gland. So I want to kind of switch gears a little bit, kind of talk about metabolic stuff, because I'm kind of on this tangent right now. I have a lot of patients that are asking about metabolic conditions that impact thyroid nodules. So talking about like diabetes and PCOS. Do you see a lot of patients that have both diabetes and thyroid nodules?
I think they're both really common conditions.
Mm-hmm.
Thyroid nodules, which in the over 40 population, anywhere between 25 and 60% of women have thyroid nodules. The percentages for type 2 diabetes and middle-aged women and older is very high. I don't know of a causal connection between thyroid and type 2 diabetes. There is one connection. Some women who have hypothyroidism, especially if it's not treated for many years, they will put on weight from the hypothyroidism and then they'll start developing things that are like polycystic ovary syndrome. Like they start missing their periods, or they'll have one period a year and it's really heavy, and they'll start getting hair growth. Everybody who you think has polycystic ovary should be worked up for thyroid, okay?
Okay.
But the other way around, does diabetes cause thyroid problems? Not that I know of.
Mm-hmm.
Does PCOS cause thyroid problems? Not that I know of. Like the three most common endocrine conditions of women right there.
Mm-hmm.
Type 2 diabetes, polycystic ovary, and hypothyroidism. And thyroid nodules are a close fourth.
Perhaps there's something that's causing both of those conditions to happen.
We know what causes nodules.
Mm-hmm.
Family history,
Mm-hmm.
radiation, iodine deficiency, and sometimes untreated hypothyroidism because your TSH is high and that tends to stimulate little nodules to get big.
Mm-hmm.
So I know you have people asking you, but I don't
All
know.
the time. That's the thing that everybody wants to know. Why do I have these darn thyroid nodules? And
Well-
it's annoying when you feel like you're trying to do everything right with your health and you still develop these nodules. So I don't know if there's really going to ever be an answer or if we'll have research for that one day. But
Well, if you were a 20-year-old woman and said, I don't want to get thyroid nodules, I'd say, okay, don't work in a dentist office and do the x-rays and don't have any children. That will improve your chances a lot. Pregnancy definitely causes nodules and it causes hypothyroidism. So it's a very common autoimmune disease, hypothyroidism is.
I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast.
Let's talk about the difference between when a patient undergoes a hemithyroidectomy and needs to add some thyroid hormone versus when they undergo a total thyroidectomy and they have complete dependence upon thyroid hormone for the rest of their life.
There's actually a huge difference between having a half a thyroid and having no thyroid. Actually, I think even a quarter of a thyroid is pretty good.
Wow.
Although a lot of my surgeons ask me, well, who do you know who's got a quarter of their thyroid left? And I say, you know what? I've seen in us patients who somebody left a quarter in, not on purpose. So I have some conclusions about that. And they can be hard to reach sometimes, the lower lobes. If your thyroid is completely removed, then you're filling up your glass from empty to full every day with thyroid hormone. It's often not enough to treat with just thyroxine either. If you're completely, the medical term is athyrotic, which means there's no thyroid anywhere. And it could be due to radioactive iodine too. If you're an athyrotic individual, it's very, very hard to get the thyroid medicine adjusted. Most of the time you have to add a little T3, which is okay. Remember, as you get older, the size of your glass changes too. You get bigger, you lose weight, you gain weight, you go through menopause. You have nothing in your system to fine-tune the thyroid hormone whatsoever. If you have a little bit of thyroid left, it's still working. So if you leave some thyroid in, now you're just topping off the glass of water every morning with your thyroid dose. A woman who's got half her thyroid out, she can probably take 50 or 75 a day. And if she misses one once in a while, it makes no difference, because she's still got a half a thyroid. If she's got her whole thyroid out, she's taken a 112 every day, plus another 5 or 10 of T3. And if her weight goes up or down 10 pounds, those doses have to change. Huge difference. And of course, if you save the whole thyroid, you're even better off.
Right.
Okay. Although half is pretty good.
Yeah.
You have to take some thyroxine, but
Right.
saving the whole thyroid is best.
Right. Ideally speaking, you would have RFA or another thermal ablation procedure to preserve the gland.
Yes.
The next best thing would be a hemithyroidectomy. Obviously, if it's necessary, you do have to take the whole thyroid out. We are very grateful to have, hormone replacement, because you would die without thyroid.
Yes. You
So,
would be dead in 6 weeks.
and I hear some patients talk about when they've had their thyroid out, they feel half dead. When they can't get their hormone levels right.
It's a terrible feeling. Oh, and there's one other factor, which unfortunately, you know how lab tests have a normal range, right? Whenever you get a lab test back, there's a normal range.
Yeah.
If you had a total thyroidectomy, you can't use any of the normal ranges for TSH, free T4, or free T3. You cannot use them. The normal ranges are different. If you happen to live in an area where there's not an endocrinologist who knows this, you're going to be told you have normal blood tests, even though you're clearly hypothyroid.
Well, what about RFA after a hemithyroidectomy? Have you encountered that yet?
Yes.
You have.
Yeah.
Yes, we
Tell me
have.
about that.
That
Okay.
was one of your patients actually. She had a hemithyroidectomy due to a very large nodule. She didn't want to go through surgery. So actually she had 2 nodules really into one. And we did the RFA, and after the RFA, actually the nodules shrank that we were able to see them individually. And she's still doing great.
Wow, that's great.
I don't know of any reason you couldn't do an RFA after a hemi. You'd get the same benefits.
Absolutely. I mean, we have so many patients who come to the community who say, I've already lost half of my gland. I don't want to lose what I have left.
The other half.
So they're very, very motivated to find a physician who will offer RFA to them or another thermal ablation.
I'm really very pro RFA. I want to keep saving thyroids as much as we can, because The procedure is promising. Yes, we're still in a learning phase because it's still brand new here in the United States. But if we keep learning from our peers across our big lake,
Mhm.
just like we have done in other areas, why not? We just have to keep going and, well, keep spreading the word.
Well, I just want to keep working with Luisa. She and I complement each other, and
You do.
we figured that out. She's really good with technical stuff. She figured out how to hook up all those machines the very first time around, and she's always done it really well. I'm sort of better on the theoretical stuff,
Mhm.
like the theories behind RFA and the
Yeah.
dosing and all that. So it's a perfect match.
I can see that. I mean, you work very well together. Yes. And
Except
you-
when I step on something with my big feet. And then it's like, uh-oh.
And I like the fact that you.
No, the problem is that we are both very organized in different ways.
Mm.
Oh, that's true.
So when you have two type A personalities and one goes in one direction, the other one goes in the other direction, you just learn how to accommodate to each other's personalities. But in general, we work very, very well. And we both know how to accommodate to each other's personalities and we just do it.
There's also another advantage, which I think maybe we didn't know at the beginning, but some of the first patients we got had huge nodules, like 7 or 8 centimeters.
Yeah.
And when you're doing an RFA like that and holding that equipment really tightly and like this, your fingers start to get numb. You can't do an 8 centimeter by yourself.
Right.
So those were our first few cases. So I said, okay, Louisa, my hands are starting to get numb. We need to switch. And so we did that. And then she did this second half. And then we just kept switching.
And it gives the other one a chance to
Mhm.
rest and communicate.
Punch on the pedal.
There you go. There you go. Yeah, that's what I was about to say was the fact that you could take turns and you can kind of critique one another's approach. Although what I saw in there was very complimentary. There was no, oh, you didn't do that right, or it was,
No,
No,
we
you don't say
we
that. You just
never
say when it's
criticize
good.
each other like that.
I'm just kidding.
You always give positive reinforcement, and we have a saying in Spanish, and I think in English, you guys say you do your own laundry in the house. We don't do our own laundry in front of the patients.
Mhm.
Right.
We discuss our stuff after we finish. If it's something that bothers him, he tells me, or I tell him.
Mhm.
But no. And very professional. We don't disrespect each other. That's why we have such a good team.
And we also have a timeout after everything is said and done. We might have a timeout next week to talk about this one
Right.
and to say what we could have done better. And I usually send her an email saying, okay, I think we should have done these things better. And
So always working to improve.
we are nonstop.
Yeah.
I also do that here in general with the clinic. What are we gonna do better? How can we stream the patients better? Because we don't have an entourage of people behind us. So it's like a chess game. Every piece has to be perfectly positioned.
We can also keep the cost down of RFA because there's only 2 people.
Right.
We don't have to pay a whole OR staff.
Yeah.
It's just 2 of us.
Yeah, and the fact that you're both doctors, you can do all of the roles. How many biopsies do you think you've done in your careers?
Oh my
Leading up to
gosh.
this.
Because I'm probably 1,000,000.
No, I'm probably in the
100
thousands.
plus.
That's the skill set you really have to have, is the biopsies and the ultrasound.
Practice is what makes the master.
Yeah,
So we have
that's-
practiced a lot.
That's what you want for an RFA person, is somebody who's already done a lot of ultrasounds and ultrasound guided needle procedures, like either biopsy or what we call ethanol installation, where you get rid of a cyst. If you've done a lot of those, then RFA is just one more step to learn how to use the equipment, but you're already familiar with the landscape.
Mhm.
It's kind of like going around a landscape. Instead of hiking, you're in a Jeep.
That's the reason why also it took us too long to get up to this point. Because before I even start helping, I have to practice a lot. So we practice a lot in phantom models. And also I have taken a couple classes with Dr. Rangel and Dr. Tufano with cadavers and practicing. So you were one in Baltimore that were 2 straight days, intensive days with a lot of practice. Until I didn't have all those hours under me, I wasn't feeling comfortable in doing all these live sessions.
So you went to we saw each other in Johns Hopkins at that
That's
training.
Johns Hopkins.
And,
And we took another one in Atlanta.
Mhm. It seemed like a really big deal that the ATA offered that workshop this year. because it's been 4 years and now they're finally offering training opportunities.
Well, it's amazing, and I'm glad they did, and I'm glad now we have guidelines,
Mm-hmm.
because now we can get those guidelines and said, yeah, this works, but no, this is not going to work, or yes, we should have add this, or we can add this other step and start making it better.
I think the ADA is a ideal institution to organize these trainings because there are already a lot of surgeons that belong to the ATA.
Right.
And of course, it has been traditionally mostly endocrinologists, but now we have nurse practitioners and PAs joining. We've historically not had that many radiologists, but still they're in a good position to like bring everybody together.
Yeah.
So yeah, I'm really glad they did it too. I went,
Yeah,
whoa,
like-
ATA is finally going to bite the bullet.
I know. I was so excited. I was
Yeah.
so glad I got to come and watch and
Yes.
see
Yeah.
what was being done, and I thought it was a great course. So I hope that they'll do it every year now.
I sure hope so.
So we'll get
Mhm.
more doctors on board. That's what patients are wanting is, they want to have a doctor in their hometown.
Different experiences, yes.
So Nashville,
Here we
Come-
are.
yeah, come see Dr.
Come
Leal,
find us.
Dr. Interlandi, save your thyroid. Yay, Nashville. So,
Thank you so much.
well, thank you
Thank
for
you.
having me today. This was fun. I really enjoyed it.
It was very nice. It was meant to be.
Save
Save
your
your thyroid.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me Again. Never forget to educate yourself and be your own advocate and save your thyroid.